Next speaker is Mr. Kiran. He's the advisor to the National Health Authority, and he'll be talking to us about building DPI from a healthcare perspective.
Afternoon, everybody. Always very hard to do a session just after lunch. So I have been given the hard task of trying to keep you guys awake, interested in probably what's it's not a very boring topic, but it's a pretty interesting topic. So I think all morning you probably heard about digital IDs, payments. All of you are familiar with, if you're here, you're familiar with the word digital public infrastructure. So the question, and I'm going to start with the question, do you guys really believe that health requires DPIs? Do you think, anybody, so what kind of a DPI could we think of for health? And anyway, what would our objective be? But to do what? I mean, what are we trying to really think what we should do? So for an IDs, you could say it's for identification for the purpose of, say, a KYC or whatever, right? Or for benefits. For payments, we are talking typically about easing movement and flow of money. What do you think we should be doing in health? Anything, is there one problem? Anybody thinks there is a problem to be solved here? Or, we definitely don't want to do DPIs for DPI's sake. Sure. So in how many of your countries can you say that any patient has access to all of their health information across all of their providers that they go to? Is it a problem? Is it a problem that you visit multiple healthcare providers but you are not able to get the data in one place for you as a patient in almost all of your countries? Same problem in India, so we are no different, right? So that is one of the problems I think we want to take up. Now, as public policy makers and public health policy makers, do you think you would want to get access to what's going on in terms of information or information patterns in health across various parts of the country? And how would you actually get access to that data? Right? So those are the kind of problems that we are really trying to solve in healthcare. So in India, there is actually a national mission. It was initially called the National Digital Health Mission, and it was renamed to the Ayushman Bharat Digital Mission. So what I'm going to try to do is over the next 30 minutes, I'm just going to try to give you like a high level overview. We're not going to get into too much details unless somebody is very interested in terms of how it actually attempts to solve the problem. And then you can then look at it and see how much of it is applicable to your own countries. So before we dive into the digital mission itself, let's take a quick look at how healthcare actually gets delivered in India. India, as you guys already know, all the numbers in India are very, very large. So, we are the country of large numbers. So, up on the top, you'll see we have almost 200,000 healthcare facilities in India across hospitals, diagnostic centers, clinics, and so on. And in general, when we started looking at digital health, the most important thing is how digitized are these healthcare facilities, who supplies software to them, what kind of software is in use at these healthcare facilities, because any digital data is of course being developed on some piece of software that's being used at these facilities. So when we did that exercise, we found that there are more than 2,000 companies in India which are making software. So by the way, if I were to go to the US and ask this question, what do you think the answer will be? What do you think will the answer be for the number of people who make software for health facilities there? Yeah, it's actually, interestingly, 3 companies in the US have more than close to 60 plus market share, 60% plus market share. And we couldn't find one company in India with a 1% market share. So it's very fragmented, highly fragmented in terms of how actually software and care providers are provisioned. Usually the software that's used at a health facility, it has its, like all technology people in this room, we love acronyms. So the health acronyms, you have software, so they're typically called health information systems, laboratory information systems, and so on. And of course, the government runs software for all its public health programs. So India has a humongous number of public health programs. I'm sure even many of the countries have public health programs with public health workers using specific software. So, for example, during COVID, when we had vaccination in India, we had a digital public good infrastructure that's called CoWIN, which kept records of all the people who got vaccinated digitally. So similarly, there's a whole bunch of software. You see those acronyms. The RCH actually is for mother and child based software. NCDs is for the things like diabetes and hypertension and so on. So there's also a whole bunch of software with health information that the government owns and kind of operates. And the reality in India is most of us Indians tend to use both a mix of public and private healthcare. So I think almost all of us who live in India, I got my vaccinations from a government facility. My dad was in the hospital just last week. We were at a private healthcare facility. And the reality is, and we also use like small clinics, big corporate hospitals, public systems, no data moves across any of these, right? So that's the reality of how things work in India. And so if you really look at what's the mix, private healthcare actually dominates in India, whether it's urban or rural. So almost 79 and 72% of the people tend to seek healthcare in private facilities and only a little bit in public. So when we set out to look at, we started asking the question, how can this idea of DPIs really be applied to healthcare? So I'm going to actually jump to the solution and then I'm going to go back first. And so, like I said before I go there, this is now a national initiative. So that means there is a department that's been identified in the government. There's a budget behind it. There's a lot of clarity about what the government has to do and who's responsible for running these digital public infrastructure and helping create a digital health ecosystem around the digital public infrastructure. I think you would have talked about, for example, for finance, how the NPCI does that for UPI, how UIDAI does that for the identity system in India, or Aadhaar. The National Health Authority is the one that does the digital public infrastructure for health in India. And what does it do? It essentially has three big digital public goods that we have identified. The very first one is called an Health Information Exchange and Consent Manager. It's called a HIECM. And its primary role is three things. The first is it's expected to help everybody get access and build their own personal health records irrespective of which healthcare provider they go to. So that's number one. Number two, it's supposed to provide a certain set of data. Completely, these are all aggregate data sets, so there is no personal information in it, which helps them do disease surveillance and interesting information for public health management. So classic example is COVID. You really couldn't manage COVID if you couldn't tell where there is a positive test case happening, how many cases were coming in different areas and so on. So this is the kind of public health data that's quite important. And the last bit is where we are trying to create anonymized data sets that can be very useful for AI. So that's the first digital public good. The second digital public infrastructure is to do with health insurance. So this one just looks at how do you move information, digital information, between a provider and a payer, if there are scenarios where there are payers. So in India, interestingly, unlike many, I don't know how it is in various countries, but most countries will usually cover both inpatient care and outpatient care through insurance if they have an insurance scheme. India, almost all insurance schemes are only for inpatient care. Outpatient care is typically out of pocket. So people pay cash when they're doing outpatient care, and they'll usually have a claim when they have an inpatient episode in India. But this digital public good is for optimizing and standardizing that interchange so that providers can get money and can actually track how much money they have to get. And the last digital public good is for digital health services. So think about if you want to book an appointment with a doctor. Is it going to be a standard experience across all healthcare providers, or it's going to vary, right? How do you do teleconsultation? So for example, in India, and in most cases, teleconsultation required both the doctor and the patient to use the same software provider. So that's how they were achieving it. In India, we have actually tried to make sure that doctors can use any software they want, patients can use any software they want if they are UHI, as we call it, UHI compliant. It's interoperable. You can actually do a full telemedicine consultation, which actually means you can find a doctor, you can book an appointment when they're free, you can make a payment that the doctor wants, you can exchange health records, you can do the video consultation, and you can get your prescription back. All of this completely interoperably using this interaction. So those are the three big digital public goods that the government in India is trying to bring to the market. Now, I'm not going to get into the details of all of them. I'm going to just step through a few so that you guys can get an idea of how these things work and then take it from there. Now, not everything, in fact, I need to update these slides. These two just went live. So we have a staged process to actually make this happen. So we start by building the digital public goods, inviting ecosystem players to come and integrate, start rolling it out, and that's when we usually say it's gone live. So this is live, and these two just went live. They came out of the sandbox and went live. We have a couple which are still in design phases, so we have not yet actually rolled it out into production in India. So this is also a digital public journey that's evolving. Of course, our identity journey and our payments journey are much older. So the payments journey, for example, started in 2015. This exercise started in 2018 and was actually started to implement. The government said, let's do it in the middle of the COVID pandemic in actually 2020. So it's only about 3 to 4 years old in terms of its journey. Now, in general, and I don't know how it is in your countries, but I have not seen a lab report in India that wasn't like a printed report, which means it really came off a computer from somewhere, right? So health information is quickly going digital. So if I look at the Indian context, and I think if I look at many of the other countries' context, you will still probably find doctors who like to talk to the patient and write a prescription on a paper, maybe tear it away and give it up. But when it comes to other things like lab reports or many other things, digitization is actually happening quite fast, and that's also very, very valuable information. So in India, it's quite common that if you go to a hospital, they will do a lab test, and after that you will get a little message on your phone, and then you can actually click on the message and you can view your report as a PDF on your mobile. I don't know, how can I have a show of hands? How many countries who are here have it in their countries? Do you guys get access to, one, nobody else? Nobody's even getting, so quite a few. So now the problem, what's the problem with this? The big issue or the problem with this approach is that we are not actually taking this digital information and making it to a longitudinal patient history. So if I want you to find that report again after a couple of months, it's unlikely that you will find it, right? And in the context of with a doctor, it doesn't happen. The second problem is that PDF is not something that it's easy for us as humans to read. It's easy for us to interpret and say, okay, this is what the report is. But let's say if I gave you the reports from multiple labs for a same parameter and say, okay, let's look at a trend of this. It's not that easy unless you have some amount of machine readability into the document itself. So that's really what we are trying to do with this mission. So one of the key things, and this I'm talking about from the first digital public good on the left, the health information exchange and consent manager. So what we do is we tell healthcare providers, hey, Mr. Healthcare Provider, if you have a piece of health information that belongs to a patient and you want to share it digitally with the patient, do that by linking it to their health ID. So interesting word here. In India, that health ID is called an Ayushman Bharat health account. So we use the word account instead of an ID because we want to kind of give the idea that we are depositing health information into your account. And so that's the idea. And the keyword here is linking, and we'll come to that as to why we have taken that as an approach. So no health information actually gets deposited, only a link to a health information gets deposited in your health account. And second, we say, okay, the information you're sharing, can you make it into a standardized format? So we have chosen an international standard that's called FHIR, which stands for Fast Health Interoperability Resources, to standardize the format of the documents that are kind of getting linked. So that's really what we are trying to do here. And what do we allow them to do? We can actually share all of these kind of things. So you can share diagnostic reports, you can share discharge summaries, OP consultation notes, prescriptions, immunization records. All of this can be linked to an ABHA, and it's by design. Actually, there were many, many more that we could have started with. We intentionally chose the most common ones, the most useful ones in healthcare, and so we started with minimal information, and we also chose things that providers were happy to share with their patients. So to give you an example of what is not shared, in India, for example, if you stay in a hospital, the hospital creates by law much more information, including, for example, your OT notes. They create something for every day of your stay, especially when you're in ICU. All of this they keep with them, and they call it indoor records. They don't like sharing it unless you ask for it. And so we have also picked the ones that they are comfortable sharing so that we can get the ecosystem started. Now, I said that all of this gets linked into something we are calling as an health account or a health ID. So how do patients actually get that? What we have given is we have created a whole bunch of apps. So in UPI, in the payment ecosystem, you saw private providers who were creating apps. So similarly, in the health ecosystem, we have invited private parties to come in and build consumer apps. We call these consumer apps as PHR apps, or personal health record apps. And there is one app from the government. So this app here you see as Arogya Setu. That's the app that the government is promoting. All the other apps that you see are apps that is coming from the private ecosystem. So we want to encourage competition, better design, better solutions for consumers from the private ecosystem. So you can download any one of these apps, and in those apps you can actually create your health account. So it takes just a few seconds for you to actually create your health account. And we also have the whole system designed for people who carry absolutely no phones or have only feature phones. So we have a card that you can get at a hospital if you are somebody who does not carry a phone or have only a feature phone, and that card actually has a little QR code that you can show and use when you actually want to collect your health record. So that's the core idea. So it's inclusive in its thinking. Even if you don't have a phone, you will be able to collect your records digitally into your longitudinal records, and you will be able to share it for your healthcare. Now, if you go to any of the hospitals, you guys are in Bangalore. In fact, this is rolled out in many public hospitals in Bangalore. If you go to a public hospital in Bangalore, you can see a little QR code that's pasted at the entrance of the hospital. So at the registration desk, you have, just like you have for payments, I'm sure you've already done, tomorrow you're doing demos, but okay. So I'm sure in India you have seen how easy we do payments with scanning a QR code. We have borrowed that for health patient registration. So when you go into a hospital, you just scan your QR and you're instantly registered in the hospital software. So you are using a PHR app. So as a patient, you could be having any of these PHR apps. The hospital is using some software that you don't, of course, know, but you can just go scan and they will instantly register you. And we have more than 100,000 patients who use this to register themselves now. Every day we call this scan and share. So it saves no typing, because the information is coming automatically. And it actually, we found that in public hospitals which had very long queues, it was able to cut the queue time down. People would wait about 60 minutes for a registration. Now with this scan, they're able to do it in about 4 minutes. So huge benefit. One of the reasons why people are using it is because they don't have to stand in the queue for registering themselves, right? Now, what would I really want you to remember? The core idea that ABDM is doing is something very simple. If a healthcare provider is generating a medical record, what we said is we want them to link it with their ABHA, and then if a healthcare provider wants to view the records linked with the ABHA, it can only be done with the patient's consent. And so India is building on this architecture, which I don't know if you guys have spoken about, which is the consent-based architecture, where you can only get access to the records with consent. And India's consent-based architecture is also very granular in the sense that the patient will have control over who they're giving access records to, which records they're giving access to, how long, and even after they have given it, if they change their mind, they have the right to revoke it and remove access to your records. So that's the power of the system that's being put behind it. So one more level of detail for people who are tech interested to understand how does this actually work. It's quite simple. So the National Health Authority, they are running this digital public, I should not use the word G there, digital public infrastructure for the country. And you'll see there are 4 boxes that you see there. The one on the top we have understood, that's basically the health account system where people can have a health account. These 2 are registries. Have you guys spoken about registries as a concept yet? Yeah. So comes to the simple question, can anybody add information to my Aadhaar? Who can add information to my Aadhaar? Who do you think should be allowed to add information to my Aadhaar? So clearly you want only trusted entities to add information to your Aadhaar. And how do you create trust? How do you know that this is really a hospital, this is really a doctor? So we do that through the idea of registries. So we have 2 registries. We have something called the Health Professional Registry, which ultimately is going to cover, so again it's got multiple purposes. So for example, India cannot answer the question today as to say how many oncologists, surgical oncologists of a certain specialty are in a certain place, right? So it's able to answer such questions, but also to be able to build trust in terms of saying, hey, you are really the entity that you are and you can participate in this digital ecosystem. So how does it start? As a user, we are expecting you as a patient to be able to first get yourself an Aadhaar. How do you do that? You do that with any PHR app, or you can get it when you go to a hospital. And what do we expect you to do with it? We expect you to share it with the healthcare provider when you visit the hospital. So you can share it by just doing the scan and share I spoke about in the previous slide, or you show your card to the registration counter which scans the card, is the 2 ways in which you can kind of do it. So the hospital basically gets now information about you and your health account, and then we expect the hospital to now use a software that's been modified to be what we call as ABDM compliant. And what that software does when it creates a new health information for you is that it links it with your Aadhaar. And the moment it links it with your Aadhaar, you will get a notification on your phone saying, hey, you have a new health record that's been added to your Aadhaar, and you can actually view it on your phone. And not only can you view it, later on if you go to another hospital or if they ask you, you can actually share it back again with your consent. And that's really the architecture that we're building, and we're building this for national scale. This approach, the health information continues to stay here, and it's only passed between this entity and the user or the other facility. So we call it a federated architecture. The government itself, and no health information goes through, even though we use the word, it's a health information exchange, but the actual exchange does not pass through it. Even if any information passes through it, it's encrypted. So it's by design, it's privacy by design, because we do not want even the government who's operating these DPIs to be able to peek into or have access to any health information without the user's consent. And that's the crux of these ideas and this architecture. So how did we get here? For people who are interested in the journey to create digital public goods in your own country, it's usually a long process, at least for us in healthcare it was. We started by writing these ideas down that India should do digital public infrastructure in healthcare. We published that as a document. That happened in July 2018. The publication was done by India's planning department. And then they said, they put it out for public consultation. They got very, very positive feedback from the market. And so they said, oh, okay, this looks interesting. Let's create a committee to see how to make this real. So the second item that happened was this committee which said, what does it take to implement something like this? And one of the recommendations of the committee was that, hey, you need to give money and you need to have a department and a strong technology team if you want to do something like this. And that was identified to be the National Health Authority. So they gave the budget and the money in the middle of COVID, June 2020. They also asked us to launch it in 3 months, which we couldn't. But we did manage to get a pilot going by September 2020. And then we really managed to get to national rollout only by 2021. So, but still a long journey. I should tell you that people like me have been working on this. I started 2016 on the first concepts, but it really took, this is the first thing that we have to show is in 2018, really on terms of the screen. So, and it's not done, I think it'll take another decade because I'll show you the challenges in terms of actually bringing this to life, because what we have brought to life is the digital public goods. The core challenge is actually getting ecosystem adoption in something like healthcare. Now, it's very clear that if we have to make this happen, we have to get, and I just maybe want to go back to, I'll use this slide and then come back. Yeah, so how do we actually get the ecosystem to participate? What does it take? And in healthcare, and probably every digital public infrastructure or every sector is slightly different. But in this case, the challenge that we have is going back to our 200,000 health facilities, how do you convince all these guys to participate? So one of our biggest issues is that we do not have strong laws and regulators who oversee it. Like for example, with financial payments, you have the RBI, which acts as a very strong regulator. India is a federal structure. There's absolutely nobody. By the way, one of the things I do, apart from working as an advisor to the government, is I run a chain of eye hospitals, and I can tell you that there is absolutely no regulators who sit on our heads and can push us to do or push the healthcare industry to make changes. So that's one of the biggest problems that we have. But even before we can convince them, we need to prepare the second layer, the software layer. If you saw the previous diagram, you'll know that we need to convince these guys to basically integrate with all of these digital public goods. So they need, if they have a version 1 of their software or version X of their software, we need an X+1 that is integrated and compliant. And so that's our first big challenge. That is, we need to get all of these guys on board, and then we need to convince them to go back, roll it out in those facilities as part of the overall thing. So far, out of the 2,000 vendors, we have convinced about 100 to complete this process. And how do we do it? We actually have something that we have created called the ABDM sandbox. So the ABDM sandbox is like an environment where we host the digital public infrastructure and we invite parties to come in, integrate with the APIs. So we put all the documentation out, we put the specification out, we have a team to handhold and explain, we run webinars to all of these development companies saying, what does it mean to make your software ABDM compliant, and how do you actually integrate, test, comply, make sure that the security is solid, and after the end of the process, we give them a key, actually a production key, which gives them access to the production digital public infrastructure. So you cannot get access to the production digital public infrastructure unless you can clear the sandbox process. And that's really the thing the National Health Authority runs. And that's the primary way with which it's trying to create this engagement with the ecosystem. Of course, just by putting up a sandbox, you don't get it. So we are also doing 2 other things. I don't have slides for it. I do have slides in the other deck. But one, we are giving away money now. So we basically said, hey, rupees 20 for every health record you link with an ABHA account for the next X period of time. Right? And we are giving that money to the healthcare provider, and we are giving money to the software provider. So it's 20 rupees to the healthcare provider, 5 rupees to the software vendor who helped him do it, so that we can actually kickstart and get the ecosystem doing. The second thing is, we are trying to make sure that this aligns. So India just passed its data privacy laws, and one of the things that the data privacy laws is, of course, health data gets covered under the data privacy laws. One of the things that is required is that all healthcare folks have to comply, and what we are trying to do is we are making sure that if you deploy an ABDM compliant software in your hospital or clinic, that's going to make it the easiest way for you to comply with the data protection bill. So those are the kind of incentives that we are driving to do for adoption. We have also broken up the ecosystem into 3 groups. We are talking separately to people who build software for the government, people who build software for the large corporate hospitals, and also people who build software for small clinics and labs, because we found that there are 3 different kind of class of groups that you need to engage with in terms of how we are doing this. So that's our journey in healthcare so far, and those are some results. So on a population of about what we are now 1.4 billion, we have managed to kind of, crore is about, that's about 10, huh? It's hard to convert. Yeah, but it's about, that's about 1/3 of the population. Huh? Yeah, about 1/3 of the population has managed to get itself an health account, and we have got about a mere 31 crore, again, sorry for the numbers, and we have about 200,000, that's a lakh is 100,000, so we have about 200,000 health facilities that have started to register, and about 200,000 health professionals have started. So the journey is on, but of course we have a long way to go for this health information and health stack to kind of pick up. Yeah, that's about it. I didn't have anything else that I wanted to talk to you folks today, but happy to take any questions or any queries that you might have. The mic's coming. You're going first?
Hi,
There's
Kiran.
somebody behind you going first. Sorry. Yeah.
I heard you speak about NCDs and others.
Yeah.
Is there any provision made for infectious diseases like tuberculosis,
Yeah.
HIV, comorbidity, any of them?
Yeah. So India does have, it has a separate program for tuberculosis. In fact, we had taken up eradicate TB by 2025 as a mission, in fact, a few years ago, but I don't think we'll hit that. But we do have vertical programs. There are almost about, I think, 23 different vertical programs. We also have specific laws which require reporting for a certain set of diseases, especially infectious diseases. So one of the things that we are also trying to do as part of this mission is try to automate that reporting. So when a lab gets a positive test for a whole bunch of, it's called notified diseases in India. If you were to get a positive hit in a diagnostic lab for any of these notified diseases, we are trying to make sure that you can send the data to the government through this mission. So it's one of the benefits of using an ABDM compliant software is that you automatically report such information.
Yeah. So this ABBA, is it based on Aadhaar?
Yes, it's one of the choices. So of the big number there, about 90% of them have a linkage to Aadhaar. So we said that the system can be used even for people without a smartphone. So how do you really provide consent without a smartphone or without any of these interfaces? So we actually use Aadhaar and we use biometric authentication as the way that you can actually provide consent in this system. And again, the consent itself is, the government kind of draws the box of the scenario so that it can restrict, make it very simple for you to know what you're consenting for as part of this. So yes, it is built on the national ID, but it is separated from the national ID because India has there's a history and there's a bunch of legal regulations in India that restrict the use of the national ID for certain purposes, right? So that was one part of it. The second reason was national IDs like Aadhaar are like permanent, right? So once you get one, you cannot change it. And we felt that for sensitive health information, people may want to have 2 accounts. So think of it like this, right? So in India, we don't restrict you and say you can have only 1 bank account to keep your money. If you want, you can have 2 bank accounts, you can move your money from A to B. So think of the similar idea here saying you have 1 identity, but you could have 2 Aabhas and you could move your information behind it if you wanted, where you kept all. So if you were going to see a doctor for a cough and cold, you may not want to give your full history which has everything, including your abortion details or your other details, right? Or your, so we think that there is going to be challenges that's going to come into play when it comes to how sensitive health information is shared by patients and wants to be managed by patients. And so we have given certain provisions. We have not reached that stage yet, but we have made provisions to make sure that the control is in the hands of the patients. And so we have given them the choice.
So do you use KYCs for
Yes.
to integrate it with
Yes,
IDA?
when you create the ABA, you have to do a KYC to do that.
Since it's always consent driven, in a case of emergencies and stuff like that, when the hospital wants to invoke the, just before an operation, wants to know the history and all, how does it work?
So we have a concept of, we have two other consent concepts, one called deemed consent and the second is called, I forget the other term that we use, but essentially we have an authorized guy. So, if somebody is a person who works at an emergency care department of a hospital, he can essentially get access to the data where he basically says, I'm overriding the system to get access to your data for this purpose. So, for limited use case scenarios, we are designing, it's not yet in production. We are designing these kind of, where he basically has an override to get access to the data only in emergency care scenarios.
So your new law will have to provide that.
Sorry?
Your new law will have to provide that.
It has to be recognized by the law. Yeah.
And so then that will go through the Aadhaar number route.
No. So the consents don't go through.
No, not the consent. The emergency provider.
Yeah. No, it will still not be linked to Aadhaar. It will be linked to the data privacy bill. The data privacy and data protection. In fact, the data protection law of India already has an exemption for health. It says that in certain health emergencies, the provider should be able to override, but doesn't specify the mechanics. And we are hoping that we can do that as part of this digital public infrastructure.
The medical supplies is also a major piece of this ecosystem.
Yes.
Does your overall framework entails the medical supplies?
Yeah,
also?
no. So we have not found a use case which is a digital public infrastructure which really covered medical supplies. So we did not. There were specific use cases within government in public health infrastructure for medical supplies, including cold chain, vaccination tracking, are the supplies there in certain places and so on. But we did not see a national level need for a digital public infrastructure. So far we have not created any digital public infrastructure for medical supplies. But there would be digital public goods or open source software, and I think that's coming up in a slide next, where we are saying for certain areas and sectors there can be digital public goods that makes it easy for adoption. Here we are really focusing on these three big use cases that I spoke about. Let me just put that slide up. It's a better slide to live on the. Yeah. So we are only focusing on these three as the big use cases in many ways.
All right, thank you. So I was more interested in the tech part of the presentation. Very good work you've done so far. So my question is, how were you able to get, you said today about 2,000 plus players.
Yeah.
Already providing some form of health softwares, right?
Yeah.
And then you brought this platform and you have 100 plus who has plugged in.
Who has integrated through APIs.
Integrate the APIs. How were you able to do that? You're taking bread from them, right?
So I don't know if we can, you can go to a browser. So just go to sandbox.abdm.gov.in.
The point is, how were you able to convince them?
How to convince them? Okay,
yes.
okay.
It's not about the
Vijay.
sandbox. I understand that concept already.
So
it's how you're able to convince them.
Money.
Money.
Yeah. So healthcare is people will do some things because it's good for other people, but mostly at the bottom of it all, it will come down to what's the financial incentive for them to participate. So it's been very clear that it's either got to be a regulatory stick saying
Yes.
You know, you don't want to go to jail,
Oh.
so you do this. Or it has to be, hey, do you want to make more money? Do this.
Yes.
So, you know, it's largely going to come to that for incentive alignment. India is trying to use a mix of both. So, the digital, the data protection bill is the stick. And we are trying to say, hey, if you want to stay, Mr. Healthcare Provider, if you want to stay compliant to the data protection bill, use an ABDM compliant software,
Okay.
right? So then the next question they ask is, hey, where do I get my ABDM compliant software? And then we say, hey, ask, what software are you using right now? You know, do you know that that guy can become ABDM compliant? So they go tell that guy, are you ABDM compliant? They're saying, if I have to stay safe, you have to be ABDM compliant. So that's the chain that we are using. And the second chain that we are using, we are saying, for the next year, we are going to be giving away rupees 20 for every health record that you link to you, Mr. Healthcare Provider, and rupees 5 to the software guy who is helping you do it. So all of this is driving a set of players to come forward and say, okay, let's get ready because there's money and there's the benefit that we'll get more business. If we are the first to be ABDM compliant, we can get more business because people will be looking for ABDM compliant software.
All right. Okay. So you also said you had an app, but you invited more people.
That's for consumers.
Yes, for the consumer. Why did you invite more people? I'm just asking.
Why?
Yes. You have an app already, and you invited more people to build around
because,
the app.
you know, see, the reality is that, let's say you have diabetes or hypertension. It's quite possible that somebody is going to make a great app for you to manage your diabetes, right? And I don't think a single government app and one solution can solve everybody's problems and needs, right?
Yeah.
Somebody with cancer may require something very different. Somebody with something else may require very different. So our theory is that there has to be an open ecosystem of participants. And we want to keep it available and open for the players, and we don't want to box it down to saying, hey, only the government can do this. So very clearly, we have taken a call saying that the let me just use this slide so that you can get a sense of it. Yeah. So if you look at this, the government's role, we have boxed the government role and saying the government's only going to do these, right? This is coming from the ecosystem.
Okay.
And the PHR apps are coming from the ecosystem with one choice from the government. So the role of the government, and I think it's very important to think about that, the role of the government is not to provide software to your hospitals and clinics. We are saying that's a private market, and the private market will provide that. Same thing, it's the private market that will provide software for patients to use and see their health records. So we want to create an active ecosystem. And the role of the government is an enabling role.
So essentially, you're not storing the data.
I am not.
The government is not storing data. It's
No.
just.
No, it has no data. It has
yeah.
no access to data, but it's enabling all of these use cases. It's enabling everybody to collect their health records. It's enabling data for public health purposes without actually the other important thing, right? If you go look at a hospital, it's probably using a software already. The government doesn't want to go and say, throw away your software.
Okay.
So it's instead giving it a path, saying, hey, ask your software guy to make a little bit of changes so that he can participate.
All right.
Right? Go ahead.
Oh, okay. My question is around telemetry, right? And to be honest, I think that's what's generally missing in a lot of the software we use. So here, there's, of course, I'm linking to health records that still sit with the hospitals.
Yes.
Now, if the hospital is offline,
Yeah.
for whatever reason, right, that record cannot be accessed when it's
Yeah,
needed.
yeah.
Okay. I assume there's some kind of track. There has to be. I mean, the
Yeah.
theme here is so. Where is the telemetry here that actually says, look, it's one thing to link a record. It's quite another to not be available when the record is needed, right?
So
how
we
do you
have
do that?
we take what we call as a two. So this is called a federated architecture, and you're absolutely right. If a node in the federated architecture is shut down, you're going to have holes in your record. So basically, all PHR apps also come with a locker or a storage. So there are two copies. There's one here with the hospital that created it, and there's two with the PHR app that you as a consumer use. So that's the thing, and when you do these sharing activities, you can either share from your app, your own storage, or you can share from the network.
If you have two copy, one with the hospital provider, one with the personal PHR app, how you design the surveillance part? Surveillance part.
Surveillance actually does not, so these are individual records. So this is a full individual record, that's a full individual record with personal information. Surveillance information actually does not have any personal information. It's an aggregate information that emits from here to a national service. So for example, just give an example, I mean it doesn't do this, but it will, for example, if I say every lab has to report how many HbA1c tests they did yesterday and how many of them were positive. So it's only 2 numbers. And that is the kind of data that will get emitted from here. It doesn't actually emit which patients they did the tests on or any of those kind of things. So that's how the surveillance data works. You can get it, you can get it if you think that you want to track it down to the individual, but in general for the public health purposes, you do not get any personal information.
For different type of diseases, for example, communicable diseases.
Yeah.
You need to have.
So only where there is a law. So if there is for example, we have something called in India we have something called the notifiable diseases law, which requires personal information to be part of the notification. Only in those cases it comes through. But for anything else which is in public health where there is absolutely no law or notification, we don't allow it.
Just for example, for a COVID example.
Yeah, COVID would probably come under the Notifiable Diseases Act.
Okay.
In fact, in India, we actually did it under something else. We did it under something called the Disaster Management Act. So basically the government will find a rule. If it wants the information, it knows how to pass the appropriate acts. Yeah.
So, how does DPI in healthcare solve for fundamental problems like lack of skilled manpower or lack of infrastructure? Can it, or if yes, how?
Yeah, so at this point I don't think, at least these DPIs that we have chosen, I don't think will do it except to provide maybe certain level of transparency and information about where the gaps are. But it won't really be able to effectively address like for example, poor infrastructure or other issues are not something that these DPIs will be able to directly address. At least that's my thesis. Please.
Just had one more question. So in relation to what the gentleman said there, in terms of the data staying at the hospitals or diagnostic centers,
Correct.
Is there some level of health data aggregation that happens on the system?
Yes.
In terms of
so there are two things that will apply, which is important I think to think about. One is on all of these guys, we are actually bringing up what we call as a data retention policy. So all of them, if they participate in ABDM, they also agree to retain data for a certain period of time. So right now for digital data, that's set, the timing that we have set is about 10 years. 10 years, right? And then on the PHR side, you as a user, you can have your own storage that you keep forever. So that's the two places of storage and that's the retention time periods you can think of. In terms of aggregation, yes. So the aggregation is happening here. It's only, like I said, some summary aggregations, and then we have, as part of the reporting, the public health system reporting, we are looking at a protocol where it gets reported for public health purposes. And we also have, so to help you answer this a little better, a corporate hospital in Bangalore does not want to reveal, say, how many cardiac stents it put last month. They will treat that as competitive information. They'll say, hey, why should my competitors know what's going on? So the data that we are looking to release for public health will typically take a large enough geographic area, say the city of Bangalore, without naming which provider. So it is privacy preserving not just for the patient, but it's privacy preserving for the provider. So no data from the data, you should not be able to go back and say that I figured out how many stents this particular hospital put last month. And we are done on time. Thanks everyone.